Hi, welcome to another American Acupuncture Council webinar. My name is Brian Lau. I'm an instructor with the Sports Medicine Acupuncture Certification Program. I also have a YouTube channel and movement-based program called Jingjin Movement Training, where we look at channel sinew relationships to movements. So today we're going to look at some manual techniques to supplement your acupuncture treatment for shoulder injuries, particularly for something like supraspinatus tendinopathy. That would be particularly indicated for that, but really a wide range of shoulder injuries. We're going to look at some manual techniques that can supplement your acupuncture treatment. So let's look at a bone model real quick, get an idea of what we're looking at. Oops, Alan, we're starting with, maybe we should start over. So let's look at a bone model first, and we'll get an idea of what our goals are for the treatment. Then we'll look at some anatomy slides, and then we can look at the actual manual techniques. So I have a scapula. So this is looking at it from the front. This is the right scapula, so we'd be looking through the rib cage on the front surface, on the ventral surface of the right scapula. Spine of the scapula is on the back, so there's the back view, but we're looking at the front view. Here's the coracoid process for reference. I'm going to put the humerus in here. So many times with shoulder injuries, especially with patients as they start getting older, we have a situation where the head of the humerus rides up in the joint and usually a little bit forward. So it doesn't get seated. It doesn't set in the joint really well, and it rises up. The big problem with that is, as you can see, is when that humerus rises up, the humerus, especially the greater tubercle, tends to bump into the acromion and pinch anything that's coming underneath there, like the supraspinatus tendon. So it tends to ride up and a little bit forward. We're going to do several techniques on some of the rotator cuff muscles to help mobilize the head of the humerus back into the joint and create a situation that allows for better healing. So that's going to be our goals. We'll look at that on the techniques, but let's look at a little bit more anatomy first. So we'll go to the slides. So this Netter image we have from above, we have the rotator cuff muscles. So the trapezius, upper trapezius is taken off. Then we have a couple other images. We're looking again at the back surface, the posterior surface of the scapula and shoulder girdle, and then we're looking at the anterior surface, pretty much what we just saw a second ago. We're looking at the anterior surface of the shoulder girdle and the rotator cuff musculature. Let's start with the upper portion. So we have the supraspinatus and the supraspinous fossa. SI12 would be going right into the belly of that muscle, into a motor entry point of that muscle for reference. That muscle then continues lateral. We would have LI16 getting close to the myotendinous junction. The supraspinatus is going underneath the acromion to attach to the greater tubercle right there. So this is a common area where it'd get impinged in shoulder impingement syndrome. We can start getting a tendinitis or tendinopathy of that supraspinatus tendon very easily because of instability there. Can't really see the infraspinatus and teres minor super well from this perspective, but we can see them wrapping around and going to the greater tubercle also. And then from the front, we have the subscapularis on the subscapular fossa going to the lesser tubercle. So from the back surface, there's a better view. We still have supraspinatus, but a better view of the infraspinatus, looking at the fiber direction going up and out. Teres minor, we're not going to look as much at teres minor in these techniques, but it'll cover it somewhat. And then subscapularis from the front, also going up and out in its fiber direction. So just an image with some points in for some reference. We have SI12 in the supraspinatus. We have SI13 in the supraspinatus. LI16. All of these are very protected as long as your measurement's good, very protected by the subscapular fossa. That needle can go straight down and it's going to be protected by bone. As long as I'm not way forward and diving the needle down through the trapezius higher, farther forward than the supraspinous fossa, that could cause a pneumothorax with deep needling there. But if I'm measured correctly and I'm relatively close to the spine of the scapula, very safe points. Sometimes people even thread from LI16 underneath the acromion towards Li15. So it's an interesting aspect is that we have Li channel points more at the tendon aspect. We have Si12, Si13, much more related to the belly of the muscle. You can go back and review and recall that the Li channel intersects the small intestine channel at Si12, and you can see that there is quite a relationship there. From the back, we have Si11, 10, and 9 kind of wrapping around the teres minor. So you can see the SI channel really relates quite a bit to the rotator cuff musculature. And then from the front, we have heart1, an opposing muscle group in the sense that it does similar activity, that it stabilizes the head of the humerus, but it does internal rotation versus these SI channel muscles, which do external rotation. So the heart sinew channel has a slight different capacity in its actions. But there's heart1 would go deep into that subscapularis. We can see it almost better from this top image, where we would be going through the axilla. The arm wouldn't be going through the anterior deltoids like this. So the arm would be up, it'd be going into the axilla, parallel with the rib cage. Deep needling into heart1 would access the subscapularis. A good technique to really learn in class if you've never done it, because there is a pneumothorax risk if it's not done properly. But we'll look at a manual technique, which is great practice for this needling technique. And it's actually a very effective technique in and of its own. Right, so one last image. So this is going to be our basic goal, is we're going to sink down into the supraspinous fossa for the supraspinatus, and we're going to slowly spread posterior to anterior. We'll do several passes covering the length of the muscle. My goal is going to be to reduce tension, I guess, in the supraspinatus, but particularly that sinking down, I want to notice that that muscle attaches to the greater tubercle. So I want to do the technique in such a way that's going to descend the head of the humerus. Same thing with the infraspinatus. I'm going to sink in and slowly spread cross fiber through the infraspinatus muscle, and using that muscle as a lever, I want to pull down the head of the humerus. So we're going to be using the myofascia to move the humerus down. So the slow spreading over infraspinatus, slow spreading over supraspinatus will have that goal of descending the head of the humerus. We can almost think about these as tonification techniques, because these muscles tend to get inhibited and they don't properly seat the head of the humerus into the joint, into the glenoid cavity. And then the final technique we'll look at will be face up. We'll be coming deep into heart1, pinning the tissue. And as the patient does movement, there'll be an influence down also to help descend the head of the humerus. But this will be more of a pin and stretch technique, and it'll be more of a sedating technique. So very frequently we have a situation where this muscle is in excess, this muscle is overactive, kind of the bully, and it tends to create a little internal rotation, pulls the joint forward, but collectively those rotator cuff muscles are failing to seat the head of the humerus into the joint. And that sets the situation up for the bone to rise up and pinch that supraspinatus tendon. This is something we work with quite a bit in our upper extremity class in sports medicine acupuncture. So this is something we go through quite extensively in our upper extremity class in sports medicine acupuncture. We go through a lot of the dynamics of this, but we'll get a flavor of this through the videos that are coming up. So let's go ahead and watch the first video on supraspinatus, and we'll come back and review some of what I just said with the infraspinatus to set up that next video. Look at some rotator cuff techniques. First of all, just a little bit of cocoa butter you can see on my finger, not a whole lot. I'm not even going to put it on patient, just kind of get it on my hands. So just a little bit of lubrication, but I want it to be mostly grab on the connective tissue, so more shearing type technique, so not too much lubrication. For the first one on supraspinatus, I'm going to have the arm up on the table. There's the spine of the scapula. I'm going to move this technique. I'm not going to use my finger like this. I'll show the full technique in a second. But I'm going to move the trap slightly out of the way so I can sink down into the supraspinous fossa. And my target will be on the supraspinatus, but I want to see the head of the humerus drop down. So this is primarily a technique to drop the head of the humerus down in the glenoid cavity, using the supraspinatus as a lever.
So I'm going to come at the head of the table, hands on the spine of the scapula, move the traps out of the way, sink down into the spine, supraspinous fossa, and descend the head of the humerus. Push down. I want to see that head of the humerus drop down. My thumbs are in contact with the supraspinatus and I'm just gently spreading over it. Spine of the scapula, descend the head of the humerus, push down. Spine of the scapula, descend the head of the humerus, push down. And I'm just covering the range of it. So kind of right at SI12, slightly medial to SI12, going closer to SI13, moving lateral to the region of LI16. And I'm just covering as much of the supraspinous fossa as I can. Last pass.
All right, so infraspinatus, just a review. I'm going to be spreading, sinking in kind of at the spine of the scapula, and I'm going to be spreading down and out, going across the fibers, but with that emphasis on pulling downward to help descend the head of the humerus. So it'll be a down and out, slow spread myofascial release type technique through the infraspinatus. Let's go ahead and look at that technique.
So for infraspinatus, I want to bring the arm off the table, about 90 degrees, unless the patient has some pain with that. You can make it a smaller angle, but my preference is to be 90 degrees. I'm going to come back to the head of the table. Infraspinatus, the fibers are going up and out, so kind of towards the greater tubercle. So up and out, I'm going to do a pass across the fibers of it. And again, it's like I want to pull through that muscle to drop the head of the humerus down. For this one, I often use a knuckle, maybe 2 knuckles. I turn my ulnar side away. That way my bones are lined up. I can start at that spine of the scapula, sink down into the tissue, move the tissue down and out, and I'm going to start to slowly spread through the infraspinatus. So just a slow stroke, waiting for the tissue to soften, not trying to rush through the tissue. Getting small fasciculations along the way. And there we go. So same thing, I'm going to go slightly medial or lateral. I went medial in this case. Sink down into the tissue to the depth of tension and shear down and out. I'm just covering the infraspinatus. So I'm at the lats now. I'm going to stop there. Move slightly lateral, down and out. Right, so one more pass. I can add patient movement with this. So the infraspinatus is an external rotator. I can have them do slight external rotation and then slight internal rotation as if they're bringing the arm back onto the table. So just to comfort, just to get a little movement as they're doing it. Go ahead and relax there for a moment. So I'm going to sink in first, drop into the tissue, and go ahead and do that slight motion now. So external rotation, I'm just holding that barrier. That's good right there. Internal rotation, go back the other way. And this way it's going to start to stretch through that tissue. That might be a little more challenging for the patient. External rotation, so the hand comes up and hand back. Good. Do one more pass there. Hand up. And then hand back. As he starts going that way, I'm going to really spread through the tissue. And there we go. That's good.
All right. So last video and last technique we'll look at will be for the subscapularis. Again, this is a really good technique if you've never done deep needling into heart 1. Not only can you get a lot of results and improvement with patients' conditions by doing this technique, and maybe that's all you ever do, but it also does set up the palpation and the sort of kinesthetic awareness of doing a deep needling technique there.
All right, so we'll look at a manual technique for the subscapularis. I'll hold off on the needling technique because I think this is best left for classroom in-person instruction if you've not needled the subscapularis deep into heart 1. And it's a safe technique if you're taught properly. You're pretty close to the rib cage. You're following parallel to the rib cage, and you're going straight down into the subscapular fossa. Though if you don't have the palpation down, the needle could advance into the between the ribs and into the pleura and cause a pneumothorax. So it's definitely a technique to learn in person with guidance if you've never done it before. This manual technique, however, will be very useful to get the palpation down. And the manual technique is extremely effective in and of itself. So I'm going to do just like I would do with the needle technique. I'm going to reach under the scapula, move the scapula out just a little bit. It doesn't move it out much, but it gives you a little bit of extra space. I have the lats, pec. I have this little triangle right in there. I'm just going to come in. Couple tricks with this is I don't want to grab too much skin because as I advance down, you can feel how that's pulling skin and it kind of stops me from going too far down. Doesn't feel great on his end. And then it stops me from doing the technique. So I need to sort of get the skin out of the way. By that, I mean I need to lift it a little bit, move my fingers around, kind of get to where I'm going to go advance down into that subscapular fossa without pulling a lot of excess skin. So I'm going to now angle straight down. I can feel the ribs on my fingernail side. And I'm going to angle straight down into that subscapular fossa. Cross fiber, feeling for bands of that subscapularis muscle. It's almost like I'm going to SI11 on the front of the scapula. So this would be deep into heart 1. So once I'm there, one of the things I can do is I can have the patient move their elbow down, following the angle of the arm, so they're kind of making their arm long. That might be enough, but if they can, then I'm going to have them start to bring their arm up, keeping the elbow out. There you go. Keeping that elbow out, bringing the fist slowly over the chest, reaching the elbow out. I really want to push the subscapularis down while they reach the elbow out, decompress the shoulder joint. So as much as they can bring you in by bringing the arm up, the better. So they're going to get the hand up. And now external rotation, external rotation, external rotation, external rotation. Right to about there. And then if they can bring the fist down towards the table. There we go. All right, so JT has pretty good range of motion, so that makes it look a certain way that is not necessarily achievable for somebody who has limited range of motion, and this technique would be too much for them. So sometimes you can't even get the arm up to 90 degrees. It's okay to back it off a little bit. I don't want to put them in an unstable position. I definitely don't want that humerus. Can you kind of shrug your shoulders as I do this? I don't want that arm to shrug up as I bring bring their arm to 90 degrees. I'm kind of working at counter purposes. So I need that head of the humerus down. Maybe I can only get them up a certain amount. I can definitely get them to reach the elbow out and decompress, kind of pull the head of the humerus down as I'm kind of pushing the subscapularis medial and kind of freeing the subscapularis. That would be enough for some people. Maybe they can lift their arm up a little bit. So you just have to work with where they are. But the starting position would be to get into the muscles. Okay, if I do this again. So to get down into the muscle, feel that subscapularis. I'm cross fibering it right now. Get on that band. I want to kind of almost bend that band and just gently reach the arm out, decompressing the head of the humerus. They could also go into external rotation here, but I like them to be able to bring me in by going into horizontal adduction to sort of bring me more into the muscle. Maybe that's as far as they could go. JT can go farther, but I'm just saying maybe a patient you're working with, that's their endpoint. No problem. I can work there, have them reach free. Maybe next week we'll come back and see if we can go a little farther.
All right, very good. Thank you for taking the time to watch those. You can see those techniques take a little bit of time, but not particularly much. A lot of that was me explaining and setting up the techniques. You could easily do this if you had the face down portion. You could take the needles out, do these techniques, spending a couple minutes going through the supraspinatus and the infraspinatus to help descend that head of the humerus. It kind of wakes up the muscles. It kind of helps give them a proprioceptive awareness so that they can more appropriately sort of pull down that head of the humerus and seat the head of the humerus in the joint. If you do a second round of treatment and you do whatever on the front, maybe even including the needling for subscapularis, you could follow up with this technique on subscapularis, or maybe you don't do the needling on subscap. This is a really great manual technique to cover that range of the muscle. Something to consider, my last thought on this, is point combinations. Is if there is this excess in subscap and more inhibition, sort of deficiency in the small intestine channel muscles, infraspinatus, supraspinatus, teres minor, a combination I use quite frequently is the source point on the SI channel, SI4, and the low connecting point on the heart channel, Heart5. So a source low connecting combination. Feel free to comment. I'd love to hear some other point combinations you guys do that might you find give good results or good responses for these types of conditions. Or if you use that low source point combination, tell me if you feel like that's been a useful point combination for you. Always nice to learn from each other, so I'll be checking out the comments and maybe we can have a little bit of a conversation about that. So thanks again for taking the time out and watching this, and thanks to American Acupuncture Council for having me. So it's always great to be able to do these webinars, and I appreciate the opportunity. Hope to see you guys next time.